So I think we'll go ahead and get started. Good morning again, everyone. Welcome to our EHE Regional Learning Collaborative session on strategies and approaches to address viral hepatitis. My name is Elena Rosenberg-Carlson, and I'm the EHE coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPTS. For anyone who might be new to the collaborative, our purpose is to facilitate knowledge sharing and support collective action across California's 8 EHE Phase 1 counties to help accomplish our shared EHE goals. And as usual, we also welcome folks from outside these 8 counties to join the sessions and learn together with us. And so it's really wonderful to see everyone here on the line with us this morning. I do want to apologize for my voice. I've been a little bit under the weather and lost my voice, but I think it's come back enough for today's session, and I'm really looking forward to a great discussion with our panelists. In the chat, you should see an option to send a message to everyone. If you haven't yet, please do use that option now to introduce yourself to everyone on the call by sharing your name, affiliation, and location. Next slide, please. So during today's session, we'll be discussing various programmatic models and efforts going on here in California to address viral hepatitis and its intersection with the HIV epidemic. This topic has actually been requested by several of our Learning Collaborative members, and we're very excited to delve into it this morning. We're going to start with presentations from our 3 fantastic panelists, and then the last 25 minutes or so will be dedicated to panel discussion and open Q&A. As always, please feel free to submit questions at any time during the session using the Q&A function on your Zoom control panel. We'll use the Q&A function to collect and respond to questions throughout the session and also during the live Q&A at the end. We'll also keep the chat function open in case you'd like to share comments or resources with the group at any time. And I also want to note that we are recording the session, and we'll post the recording and the slides on our EHE Regional Response webpage within the next week. So now we'll get started with Brian Risley, who's the manager of HIV/Hep C health promotion and HIV programs at APLA Health, and also co-chair of the Hepatitis C task force for LA County. Thanks for joining us this morning, Brian.
Thank you, Elena. Happy to be here.
Great, and we'll get your slides shared here.
Great. So our opening session is a community-based model on hepatitis C advocacy in Los Angeles. And I have been the co-chair of the Hepatitis C task force for Los Angeles County almost since its inception. This is our 20th anniversary. So I'm excited about that. I'm excited about all the progress that has been made in the treatment of Hep C and in the infrastructure in public health for hepatitis C. Next slide, please. So our mission statement, and this has been our mission statement now for 20 years, is the Hepatitis C Task Force for Los Angeles County is a group of private and public agencies, advocates, and concerned individuals working in partnership and collaboration to prevent the spread of hepatitis C and other viral hepatitis, and to improve the quality of life of persons affected by hepatitis through education on risk factors, harm reduction, and cure treatments. Next slide. So we were established in 2002. We were originally under the aegis of homeless healthcare. And when I became co-chair shortly after that, I brought it under the aegis of APLA Health, where I've worked for 20 years now, to give it a home and also a 501c3 so that we could fund the nonprofit all volunteer task force. We were formed to address the lack of services for people at risk for living with Hep C, and our members include many Los Angeles County-based consumers, federally qualified health center staff, community-based organizations, representatives from Department of Public Health in LA County, and medical science liaisons from the pharmaceutical companies. They provided a lot of informational support. We meet quarterly, and we have a couple committees, a policy and advocacy committee, and then a prevention, education, and awareness committee. Next slide. Our goals have always been to advocate for hepatitis C policies and funding to increase public awareness of hepatitis and develop and enhance systems of hepatitis C prevention, surveillance, testing, education, treatment, care, and support. And this has been a large task for an all-volunteer task force. Next slide. So some of our highlights, some of our accomplishments over the last 20 years. We've participated in multiple CDC-funded prevention planning conferences for Los Angeles County. There have been in the past 2 CDC-appointed adult viral hepatitis coordinators. The CDC does not fund that position anymore. Fortunately, we have a lot of guidance from Dr. Prabhu Gounder, who is with Department of Public Health, and recently received a large CDC grant, mainly for surveillance, but also to provide some education and more rapid testing. Over the 20 years, we've produced 20 annual Hep C summits. These are very large regional summits where we talk about topical issues around viral hepatitis with a focus on Hep C. We have created a Hep C resource directory for LA County, and this we update every other year. It's quite a task because it's now grown, obviously, in size and resources. And so this, for our 20th anniversary, we'll have a new edition, updated Hep C resource directory. We've done about 40 C retreats, and what those are consumer education and outreach activities where we go, let's say, to a drug treatment program, and we provide Hep C education and linkage. But we've gone to hospitals, we've gone to clinics, and many other settings where people are either at risk or are currently getting tested for Hep C. We have done support groups for people who were newly diagnosed and people living with Hep C. As you know, we've only had the direct acting agents that have proved to cure Hep C just really within the last 10 years. And so before that, that we had 40 and 50% efficacy with the Hep C drugs. And so big improvements with direct acting agents. We've done 15 annual screening events to promote Hep testing and prevention. And we've had about 10 years of LA County legislative breakfast where we've invited Board of Supervisors, City Council, other people who are key stakeholders in the county. Next slide. This is just a cover from 2 years ago. And we always put a program together for our annual Hep C Summit. Next slide. And as I said, this is our 20th anniversary. And save the date, we'll be sending out a save the date flyer actually Tuesday, December 5th at the California Endowment. And our summit theme is HCV elimination initiatives in Southern California. Our learning objectives for this year's summit: describe the viral hepatitis initiatives for Southern California, explain strategies to eliminate new Hep C among people who are using drugs, and identify ways to integrate HCV test linkage and treat into FQHCs and other priority settings. Next slide. And our directory, as I mentioned, just some of the resources that are available in the guide. We provide a whole section on where you can get tested for viral hepatitis, where you can get treatment, and where to receive vaccinations for Hep A and Hep B, viral hepatitis support groups, needle and syringe exchange programs, where to find patient health navigators for linkage, or to help somebody just through the treatment process, and education resources and counseling. Next slide. During National Hepatitis Awareness Month, which is May, Hep B Free Los Angeles and San Francisco, the Hepatitis C Task Force for Los Angeles County, and National Viral Hepatitis Roundtable have coordinated hepatitis screenings and a new public service announcement. And we've done this multiple times to highlight prevention of Hep B and C, which together cause almost all liver cancers worldwide. Next slide. And we are, these are our limitations. We're a group of dedicated volunteers. We do have limited resources. So every year we have to use our 501c3, raise funds, try to accommodate staff time where everybody else has, including me, a full-time job, and to accomplish our goals. Our advocacy is, we can only make public health recommendations, which we've done many, many times. And sometimes they do end up changing guidelines. And for instance, was where California State Medi-Cal had some barriers to Hep C treatment. We were able to get a couple experienced doctors who treated Hep C and HIV to help sort of petition California Department of Public Health to change the guidelines and make Medi-Cal more inclusive of treating Hep C. Those barriers have now been eliminated. So one success story of many, but basically it's been a lot of work. Next slide. And currently we're supporting community viral hepatitis elimination. We're working with Department of Public Health, who have a 5-year viral hepatitis action plan. We've been through many cycles of these 5-year plans, but I feel very confident now with leadership in public health and with the task force that we can meet these goals of identify and convene key stakeholders, catalog services provided along the care cascade, identify opportunities for collaboration to overcome the gaps in the cascade, and develop indicators based on available data to track our progress. And we want to continue to strengthen and engage community coalitions, the task force being the main coalition, to provide backbone support to this 5-year viral hepatitis action plan, which is part of eliminating Hep C in LA County. Next slide. Yeah, so that's a snapshot of what we do of community advocacy at 20 years. I'm proud of all our efforts, and we'll continue. I hope to see many of you at our 20th annual Hep C Summit. So thank you.
Wonderful. Thank you so much for your great presentation, Brian. And just really appreciate learning about the important work that the task force is doing in collaboration with partners, both locally and also obviously across the state and even nationally. So thank you for that. As a reminder for folks on the line, if you have questions for Brian, feel free to submit them directly to the Q&A box at any time, and we'll get those questions answered during the live Q&A at the end of the session. So thanks again, Brian.
Great, thank you.
All right, so next up we have a presentation from Dr. Shubha Kherkar, who is the Director of Infectious Diseases and of the Hepatitis Center of Excellence at DAP Health. Welcome, Dr. Kherkar.
Thank you. I'm going to start first the screen sharing.
It looks like there's just a little black bar over the lower left-hand corner of your slides.
Are you still seeing it? Sorry.
That's okay, no worries. We are still seeing it. Would you prefer that we share the slides?
Yes.
Okay, we can do that, no worries. Enrique, can you? Thank you so much. Perfect.
Thank you so much. It was really an honor to speak to this group and give you a spotlight on the Hepatitis C Center of Excellence. Actually, it was a viral hepatitis Center for Excellence, but today I'm going to mainly focus on the hepatitis C. And what is the real world view of this pandemic going on for over 50 years now. Next slide, please. So now that we have a cure for hepatitis C, where more than 96 to 98% can be cured, it is still a beast that needs a very different strategy from hepatitis B, which is vaccine preventable. And yet we have several million, at least 100 million people that have hepatitis C, and they all can be cured. And that's who we are dealing with. But in this slide, it's the bigger beast. Next slide. So the WHO goal was set for 2023 to have at least all people tested and linked to care, and hopefully 80% reduction in the incidence of chronic hep C and reduce mortality by 65%. These are things that were achieved well before, but some of the daunting tasks are still postpone these goals for everyone. Next slide. So the hepatitis C virus is the only virus that has been cured in the last 3 decades, actually, from finding the virus as a cause of transfusion-related hepatitis and coming to cure within 3 decades. Next slide. So discovery to cure occurred sometime where nearly 96 to 98% people could be cured if they have hep C. Next slide. So from an infectious disease specialist, we tried to find out what we already know and how to tackle this in our community. So every Hep C patient can be cured. Cure as prevention of transmission. Cure prevents advancing to late-stage disease, morbidity, mortality, and helps decrease the healthcare burden on liver disease and hospitalizations. Next slide. Now, collaboration of FQHC and managed care organization was our theme here in Coachella Valley, where we estimated based on some heart data that there are approximately 4,000 individuals that might have hepatitis C. Next slide. So the model that we were going about was based on our HIV experience in something called Get Tested Coachella Valley Initiative that became a significant process that was started in 2014, and a 5-year experience was based on projection to reduce transmission to the next generation. So if everyone knew their HIV status with free and escalated testing, linkage to care and treatment, that infection would be unable to be transmitted to newer generation. Next slide. Main successes of this was the linkage to care and escalated testing in Coachella Valley. There were over 100 or so testing sites that provided a testing, and a bunch of people. These are the people that participated in linkage to care to a treatment experienced or HIV provider in starting antiretroviral treatment, achieving antiviral suppression, and therefore preventing transmission. Next slide. So the success of this is where we tried to model Hep C care cascade. So in the 5 years, 92,000 total HIV tests were performed, and approximately 590 some patients who were HIV positive were linked to care. And nearly 95% of those that were linked to care were initiated on treatment, and 97% of them achieved undetectable viral load. So the question was whether we could reproduce the same type of success in hepatitis C, in which case that in July of 2017, we added free testing of hepatitis C to this project. Next slide. So the elimination concepts exactly were based on population, where if we could find that curing hepatitis C was faster than the rate of new infections, and if we found everyone that had hepatitis C were linked to care, to Hepatitis C Center for Excellence, and treatment leading to cure with navigation teams all the way to SVR or cure, that we could probably put a dent in this pandemic. Of course, other strategies had to continue, such as prevention by education, harm reduction, treatment reducing transmission, and of course, other advocacy that Brian talked about. And then we were particularly considering novel collaboration, such as a managed care organization, which has nearly 80,000 approximately members, and FQHC focused on communities, that we could perhaps create a process of rapid testing, treatment, and cure. Next slide. So the Hep C care cascade, the part that was significant and easier to do was the one in the red block. From evaluation, when the patient actually presented in front of us, that part was the easiest part. The one prior to that, which is prevention, the antibody testing, the PCR testing, and the linkage to care, those were the challenges. Next slide. And so we focused on the three elements of getting patients to care: screening, linkage to care, and quality of care provided, all the way to cure. But all we were really focusing on was the tip of the iceberg, because the challenges were deep and substantial. And some of the individuals with Hep C were in a category of being in a managed care organization, and others were in the category of FQHC reach. Next slide. We presented this poster of overcoming Hep C elimination challenge in ID Week in 2019, trying to state the modeling of Hep C care cascade in Coachella Valley with this objective. Next slide. And of course, the processes were similar, because the Center of Hepatitis C, Center for Excellence, and around it was all the resource sharing, as well as expertise and other things that could be collaborated to reach as many people as we could. And that was the objective of this challenge. Next slide. Previously, a Ryan White Clinic, DAP, now is a federally qualified healthcare. And the managed care organization, the Desert Oasis Healthcare, collaborated from 2015 to 2020 in the pre-pandemic times with Hep C, escalating testing, treatment, and navigation to cure. Next slide. So in the center, we provided community outreach, free testing, education, and counseling. Sexual wellness clinic also tested for hepatitis C. All of the members that were in care in the primary care at managed care organization also got tested and linked to care. Linkage to care was essential to all to determine if they needed navigation through to the end visit of SVR, referrals for other things such as health, addiction, behavioral health, addiction, and transportation, etc., were taken into account. And I will now outline the successes and the challenges, and then some ideas. Next slide. So Hepatitis C Center of Excellence had amazing pharmacy-driven processes that could be rapidly, put patients through the treatment plan. Linkage to care was a robust plan that focused on serving the community, especially the marginalized population who had difficulty getting through to the end for cure. We had infectious disease consultant that were engaged in both sides, the FQHC and the managed care organization. Next slide. As we can realize, managed care organization is member-centered, and FQHCs are centered on the social determinants of the health. And these two came together through the Center for Excellence for getting through as many as quickly as can be treated. Next slide. Treatment as prevention of transmission was the objective, and we were balancing rapid treatment against cost of treatment. Treating patients between the ages of 15 to 45 was really focused on reduction of transmission, whereas treating people living with hepatitis C was also to reduce liver disease burden on hospitalizations, mortality, morbidity. Next slide. So this is DAP. I would like for you to progress the slides quickly, because this is practically just a visual for what Hepatitis C Center for Excellence was. Next slide, and next one, and next one. So thank you. Next slide. So what were our successes? So we did demonstrate that there was increase in free Hep C screenings on a yearly basis until, of course, 2020, when we had to split because of the COVID pandemic. But getting your attention to the sexual wellness clinic, they tested over 20,000 individuals and found 314 positive for hepatitis C, suggesting that even in the risk groups, unless it was 66 times tested, that you would find the one that's positive. So that is the challenge, even in asymptomatic individuals, where if you need to find all the 4,000 suspected or estimated individuals with Hep C, that escalating testing was extremely important. We also did outreach, education, advocacy, free testing, counseling through our amazing group of individuals who went to 40 different sites in the Valley, educating, counseling in prisons, in addiction centers, rehabilitation centers, methadone clinics, etc. We had, similarly, what Brian mentioned, Hep C Forum events to reach primary care clinics, residency programs at the hospitals here in the desert, other managed care organizations to scale up on testing and referral, and then a linkage to care and navigation team was instrumental in getting these patients linked to care. Next slide. We had success in treatment getting started, supervised by skilled pharmacists trained in Hep C in prior authorizations, and except for Medi-Cal, almost all of them needed other assistance. Next slide. Next slide. And we had significant success in linkage to care even through the pandemic. This was an example of nearly 98% of those referred for Hep C were linked to care with at least 1 or 2 visits with the providers at the Hep C clinic. Next slide. And statistics of Coachella Valley, just to summarize, that between 2016 or around that time until about December of 2022, so far is treatment, cured or SVR estimated was around 923. This is based on several different data extractions because of the split of managed care organization and DAP Health had to do due to the COVID pandemic because of other infectious disease priorities in the community. and based on prescription records. Next slide. We also had to deal with other hurdles in being deflected, but we still maintained on harm reduction, opening up an Indio clinic that offered Hep C testing as well, along with HIV and other STI screenings. Next slide. So now, having said the successes, the challenges are still daunting, and currently still there is undiagnosed patients. Opioid crisis is still fueling the new infections, and it was definitely worse during the pandemic, which is when we lost momentum, we lost manpower, we had to split up to preserve manpower and engage in dealing with the pandemic. But we kept our doors open through the pandemic for treatment and linkage to care, even for hepatitis C on both sides. Both the managed care organization continued to treat as well as we did. And we tried to work on provider knowledge gaps in the care of new infections versus chronic infections. Next slide. Of course, the statistics is daunting. This is data captured through courtesy of AbbVie's mapping Hep C based on lab reports of two major labs that do antibody testing. And next slide. This is for the California, how many are tested and how many positive. And then Coachella is also a long ways to go. Next slide. Challenges in treating persons using intravenous drugs, of course, remains a task, continues to be a task that we are aware of. Next slide. Challenges of reinfection. The truth about cure is that you're not going to be immune unless you educate, counsel, and support every individual that goes through treatment at the time of a cure, that you help them understand how to stay cured. Next slide. And challenges in treating elderly with liver disease, sometimes too late to test, too late to refer, and the comorbidities. Next slide. This is to illustrate that the span of Hep C can be as long as 25 to 50 years. And by the time they are found and tested and treated, it could be late. Next slide. This just illustrates missed opportunities to treat in individuals who are asymptomatic. Next slide. And next slide. So, hepatitis C, HIV, and hepatitis B rapid test diagnosis was something that I just found this in scientific report that collaborated accurately. And if we could test and treat as quickly as possible, removing barriers to treatment, if HIV positive refer to rapid start for treatment, if hepatitis B negative, immediate vaccination, and hepatitis C treatment. And this was demonstrated in a Melbourne gay men's study, successfully showing 83% reduction in Hep C. Next slide. So what lessons did we learn? We must understand the hepatitis C care cascade. We have to escalate testing. We have to have increase in testing sites. We must continue to have linkage to care and navigation staff and give them the tools they need to provide and reach patients that are marginalized in drug rehabs, or to provide incentives for treatment completion and staying cured. We must train even community-based treatment centers all over where at least clinicians and pharmacists can easily escalate and follow the treatment cascade. And then rapid testing, rapid diagnostics at point of care with immediate linkage to care and rapid test and treat strategies might work. Other ideas such as street medicines, volunteers in medicines, going out in the community and directly observe treatment at methadone clinics may have been considered elsewhere. Next slide. This is not just in US. As you can see, this is global initiatives that are all over for eliminating hepatitis C all over the globe. Next slide. My presentation was to get motivated for Coachella Valley. These are our partners in the process. We have been trying to reach every one of them. Next slide. And we appreciate that they started participating in these ventures with the Get Tested Coachella Valley HIV initiative. Next slide. Thank you very much. I'll be able to answer questions if you have, but I hope this brings some real world experience to the panel and to all that are attending.
Wonderful. Thank you so much, Dr. Kirkar. Very, very informative presentation. And we do have a couple of great questions already coming into the Q&A for you. And I do want to just remind our attendees on the line one more time that if you have any questions for our fantastic panelists, feel free to enter them anytime directly in the Q&A box on your Zoom control panel. So Dr. Kirkar, thank you again. We'll follow up with you at the Q&A. And meanwhile, we're going to introduce our final panelist this morning, Rachel McLean, who is Chief of Policy and the Viral Hepatitis Prevention Section in the STD Control Branch at the California Department of Public Health. Thanks for joining us, Rachel.
Hi, good morning. Thank you so much for having me. Can you hear me okay and or see the slides okay?
Yes, both look great, sound great.
Wonderful. Okay, well, thank you so much for having me. My name is Rachel McLean. I also go by Ray. My pronouns are she or anything respectful. I'm with the California Department of Public Health. And I was invited to talk about strategies for integrating viral hepatitis into your HIV program. And I think the previous presentations were a great segue. I heard a lot of bits and pieces that I want to pick up on if I can. So just to, I think the previous presentations maybe made this case already, but just to kind of start with the basics of, I'm someone who needs to focus on meaning and the reasons for doing things. So I'd like to just start with the basics of why should we integrate viral hepatitis into our HIV programs. Obviously, HIV, hepatitis B, and hepatitis C have overlapping transmission routes. HIV increases the risk of sexual transmission of hepatitis C, and also increases the risk of vertical transmission of hepatitis C at birth. People with HIV are less likely to clear Hep C on their own, and are at higher risk of developing liver disease about 10 years faster than people who do not have HIV, although that is less if someone's HIV is virally suppressed. There's overlap between HIV and hepatitis B medications, and also some HIV medications can affect the liver. And so it's just very important for, really these are syndemics that sort of travel together with some exceptions. And so this is one reason why it's important to integrate our services. These are very old data, with apologies for not having anything recent, but we did an analysis a number of years ago looking at our HIV surveillance data in California to understand how many people in our state had known co-infection between HIV and hepatitis B, as in boy. This is likely an underestimate, but we found that among people with HIV, about 5% had a known hepatitis B co-infection, and people who were Asian American, Native Hawaiian, or Pacific Islander were more likely to have both HIV and Hep B versus having HIV alone. That's because hepatitis B is very common in Asia and the Pacific Islands, mostly because hepatitis B as a virus has been around for thousands of years. It's been found in mummies in Egypt, which I think is pretty cool. And that just happens to be where hepatitis B has traveled over time. In terms of hepatitis C, also the estimates we have are quite old, but we did an analysis of 2016 data of people with HIV in California, how many had known co-infection with hepatitis C, and it was about 11%. The true number is probably higher for both Hep B and Hep C because many people are undiagnosed. Among people with HIV and hepatitis C co-infection in California, they were much likely to have reported injection drug use compared to people who had HIV alone, which makes a lot of sense if you think about the overlapping transmission routes. Hepatitis C is most often transmitted through injection drug use, although as the previous presenter mentioned, before 1992, hepatitis C was in the blood supply. So there are many people who have Hep C who were infected through healthcare related exposures. So we talked about the why, and just to briefly describe the what should we do to integrate viral hepatitis into our HIV programs? The first thing we can do that doesn't cost anything is to educate our clients about the overlap in transmission routes, how to prevent infection, which types of hepatitis are prevented with a vaccine, which ones could be treated and cured. The hepatitis ABCs can be confusing for a lot of people, and so it's important to remind folks that hepatitis A as in apple and B as in boy can both be prevented with a vaccine, but there is no vaccine against hepatitis C as in cat. CDC recommends that all people with HIV and people at increased risk should be vaccinated against hepatitis A, and all adults and people with HIV should be vaccinated against hepatitis B. So basically all of your, most of your participants should be vaccinated against hepatitis A and B, which can really prevent liver disease and as well as transmission of infection. Another way to prevent viral hepatitis is to promote access to safe injection equipment. Dr. Kirkard talked about the sterile syringe services program that they started, which is wonderful. Also, strategies that are known to reduce hepatitis C transmission among people who inject drugs are medication for opioid use disorder, such as buprenorphine or methadone, as well as there's not as much literature on contingency management for methamphetamine or cocaine use. and its potential for reducing hepatitis C, but it's really one of the only evidence-based interventions that we have for meth use. And so I would imagine if people inject less frequently, that they would probably be at lower risk for hepatitis C. In terms of testing, all adults with hepatitis B and hepatitis C should be tested at least once in their lifetime. This is a new recommendation from CDC. All people with HIV and people at ongoing risk should be tested periodically for viral hepatitis as well. And people that are being considered for HIV pre-exposure prophylaxis or PrEP should also be tested for hepatitis B. I'm not a clinician, but my colleague, Dr. Phil Peters from the State Office of AIDS wanted me to mention that the medications used for oral PrEP are actually the same that are used to treat hepatitis B. And so it's just important for people to know if someone has Hep B, because if they stop using PrEP, there can be a risk for brief inflammation of the liver. And so it's just important for that testing to be done, but PrEP is not contraindicated for people with hepatitis B and can be used safely. What else? So in addition to educating, vaccinating, preventing, and testing, we can also treat. Hepatitis B can be treated. It cannot be cured, but treatment can suppress viral replication and help protect the liver from liver disease and liver cancer. Hepatitis C can be cured, and as the previous speakers mentioned, new treatments have really changed the game for hepatitis C since 2014. The bad old days of interferon and ribavirin are over. Hepatitis C can be cured in 8 to 12 weeks with all oral medications with minimal side effects that are equally effective for people with and without HIV, that are very effective for people who use drugs, people with substance use disorders, people with serious mental illness, people with HIV, African Americans, all groups that used to not have as good response rates to the previous regimens of pegylated interferon and ribavirin can be effectively treated and cured with the new all oral medications. But a lot of people on the street don't know that. And so it's very important to promote that message when you're doing outreach in the kinds of settings that we have been talking about. We did an analysis of, I really consider, curing hepatitis C among people with HIV in California like a winnable public health battle. But what we have found is that in our surveillance data among people with HIV Hep C co-infection, they're often out of care. And sometimes even if they're in HIV care, their Hep C still has not been cured. And I would be interested in hearing from the people on this call why you think that's the case and what it would take to change that. So one of the things that we've been doing in California at the Department of Public Health and in close collaboration with the Ending the Epidemic's counties and our other community partners is working to develop, as far as we know, the first integrated strategic plan that both addresses the syndemic of HIV, hepatitis C, and sexually transmitted infections, and is also centered around the social determinants of health rather than centered around the diseases. Because as the previous speaker mentioned, the sort of tip of the iceberg is the diseases themselves, and really the iceberg itself is the social determinants that are driving transmission. So the 6 social determinants of health that our plan is centered on include racial equity, housing first, health access for all, mental health and substance use, economic justice, and stigma. So I'm going to talk briefly about some of the opportunities that are available in each of these areas. I'm not sure how much time I have, so I might not go over all of my slides, but hopefully this will give people some ideas about how to support your work integrating viral hepatitis into your programs. So in terms of racial equity, In 2019, the state allocated $4.5 million for local assistance for hepatitis C related activities. We are funding 22 local health jurisdictions. The funding formula accounts for local health jurisdiction specific Hep C racial disparities. Hepatitis C disproportionately affects African American and Black people and American Indian and Alaska Native people in California due to systemic racism. And so we accounted for that in our funding formula. And the cool thing is that at least 50% of these funds must be used to support a community-based organization in the jurisdiction, either through direct funding or through in-kind support. So this is really helping to increase the capacity for Hep C services on the ground in a way that is really unprecedented. This is the first major investment of ongoing state general funds in California's history. These are the jurisdictions that are being funded, which overlaps with the Ending the HIV Epidemic's jurisdictions for the most part. The funding amounts that we're giving are not earth-shattering. It's about $200,000 for each jurisdiction, and they have to give half of that to a CBO. So it's really just kind of a down payment on some of the services that are really probably needed. But this does represent the jurisdictions that cover 83% of non-prison-based Hep C cases statewide. In terms of the scope of work of what the jurisdictions are funded to do, there are two major parts of the scope of work. Part one is based on public health surveillance and case follow-up. All jurisdictions are required to follow up on acute hepatitis C cases, and they are given the option to use their funds to focus on special populations, including children, adolescents, and young adults, as well as people with HIV Hep C co-infection. And about 11 counties are using their funds to focus on people with HIV and hepatitis C. In terms of the second part, which is really focused on those CBO collaborations, the funding is to be used for antibody testing, RNA testing, patient navigation, and care coordination, which are all the services that the previous speaker was talking about. So this is, it's encouraging, and I would, encourage any CBOs that are on the call to learn more about what's going on in your jurisdiction if you're not already familiar. In terms of housing, in 2022, the authorizing statute for this $4.5 million in general fund that I mentioned was modified to allow the funds to be used for material support, mostly for people experiencing homelessness, including sleeping bags, tarps, shelter, clothing, and hygiene kits. So people, for example, could be put up in a motel during their Hep C treatment. But keep in mind that the total grant is only about $200,000. So it's really not enough to house people, but it's more just providing the flexibility if there are special circumstances, where this might be needed. The great thing is that Department of Healthcare Services is part of the California Advancing and Innovating Medi-Cal, or CALIM initiative, has new Medi-Cal benefits for housing navigation and supports for Medi-Cal beneficiaries. Honestly, there's like many billions of dollars available in Medi-Cal as opposed to a few million for hepatitis C specifically. So we're really looking to increase awareness about these benefits and encourage our partners to leverage these opportunities to increase housing support. In terms of healthcare access and testing, in 2021, we received a separate allocation of $1 million for hepatitis C rapid test kits that we're giving out to eligible health jurisdictions and nonprofit CBOs. In the past, we've given DAP Health Hep C rapid test kits, which I think supported some of the activities that you just heard about. We also have, sites that we give test kits to in Los Angeles. So there's a lot of overlap here. In 2022, California law was amended to require primary care facilities to offer adults Hep B and Hep C screening in accordance with the U.S. Preventive Services Task Force guidelines if it's covered by their insurance. So we're trying to really increase awareness about this bill, because if you're wondering whether to do Hep C testing and you're offering primary care, one way to get buy-in from your leadership is to tell them that it's actually required by law now. That might help. We also just received in 2022 an appropriation of one-time funding of $15 million to support routine opt-out, HIV, hepatitis C, and sexually transmitted infection screening in emergency departments. And we're working with the Public Health Institute California Bridge Project to support them in putting out a request for application for those funds. We're also working to increase access to test training for HIV test counselors, which I know has been a real challenge and could be a whole, 2-hour conversation in itself, but just want you to know that we are working on it furiously. And in the future, the integrated training that will be available will include information on how to do the syphilis rapid test, but we're not quite there yet. In terms of healthcare treatment, the AIDS Drug Assistance Program does include hepatitis C medications, and some prior authorizations were recently removed. And as Brian mentioned, Medi-Cal has removed the prior authorization requirements for all but one Hep C medication. And so it should be pretty easy to write a prescription now. There's not all the paperwork and hoops to jump through that there used to be. I did see a question in the Q&A about why health insurance doesn't want to cover Hep C treatment. If there's a health plan in your area that's not covering Hep C treatment, please let me know. I would love to follow up with you. So please message me in the chat and I'll follow up on that later. We're also collaborating with 2 different Project ECHO initiatives in California, one at University of California, San Francisco, one at USC, to train primary care providers how to treat Hep C in primary care. Hep C does not need to be treated by a specialist unless someone has end-stage liver disease or is in kidney failure or something. Hep C can be safely treated in a primary care setting. In terms of future opportunities, there is an initiative that DHCS has an initiative to increase pre-release planning and transition services in local jails. And there's some indication that that could be used to pay for Hep C treatment in jails, although it's not totally clear to me if that's really gonna be how it plays out. So we'll see how it goes. In 2024, Medi-Cal is being expanded to all eligible adults, regardless of immigration status, which is great. And there's also some pilots going on with FQHCs that will allow them to bill for same-day services and for street medicine. So I think there's just an increasing recognition that we really need to bring the care to the people and not sort of wait for them to come to us. Also, in terms of preventive services, CDPH supports syringe services programs with a supplies clearinghouse. California Bridge through DHCS funds substance use navigators and emergency departments. California requires licensed methadone clinics or narcotic treatment programs to test all of their clients for Hep C and to offer HIV testing and intake. So we've developed some FAQs that I can put in the chat later for these programs to help them think through how to implement those recommendations. I'm sorry, there's just so much going on. I've probably gone over my time, so I'm just gonna, I think, skip through some of this. We're working on integrated outbreak response planning. DHCS also, Medi-Cal has added a benefit to cover community health workers, which can be used for navigation. And we're working to increase collection of sexual orientation and gender identity data to promote equity and reduce stigma. And DHCS just launched an anti-stigma campaign for people with substance use disorder. And I encourage you to check it out and contribute your own stories. So I know that was a lot of information. I would just encourage you all to think about, what is one thing you can do to start addressing viral hepatitis in your work this week. Think about what barriers you anticipate, what resources would help you get started. I have a ton of resources in my slides, which I'm hoping the presenters, the organizers can send out. There's clinical guidelines, free training, resources on where to find testing and treatment, information about the formulary for ADAP, dear colleague letters on the laws that I talked about, all kinds of stuff. So thank you so much again for having me. I'm sorry if I went over, and look forward to the discussion.
Great. No, thank you so much for your presentation, Rachel. And I just really love how you emphasize both why and how to think about integrating efforts to address viral hepatitis in our HIV programs. I think that was very helpful, and we will be sharing all of the slides with everyone after the session today. So folks can look out for those great, many resources, both in your presentation and in our other panelists' presentations can be accessed after the session through those slides. All right, so now I'd like to invite Dr. Karkar and Brian to join us again for a bit of panel discussion and Q&A. And we're also going to have Lena Khan joining us for the Q&A, who's a pharmacist at Desert Oasis Healthcare, who works closely with Dr. Karkar. So welcome, Lena, as well. All right, so we're going to begin with some panel discussion on a few of the topics that participants asked about during registration, and then we'll move into open Q&A. So again, attendees, feel free to continue submitting questions in the Q&A box as you have them. So multiple participants during registration shared that their counties and/or organizations' HIV program does not prioritize hepatitis, and they'd really like to learn about potential ways to feasibly include it in their HIV-focused programs. So the question is really, what are a few high priority strategies that our panelists would recommend HIV programs consider folding into their current practices to ensure viral hepatitis is being appropriately addressed? And Rachel, I know you already spoke a little bit to this question in your presentation, so maybe we can start with you and then see what Dr. Karkar and Brian have to add.
I mean, I think my recommendation is really just to start wherever you are, you know, and not try to like take it all on at once. Like if you don't have any, you know, if you're doing rapid testing for HIV, could you also do rapid testing for hepatitis C and for potentially for syphilis? If you're doing education, could you just kind of put up a poster in your waiting room, or, you know, just add 5 minutes to your support group about hep C, or like invite someone from Brian's group who has lived experience, right, to come talk about their lived experience in your support group. If you're doing phlebotomy and you're doing routine opt-out testing, add hepatitis C to the panel along with HIV and syphilis, you know, like just whatever you're already doing, I would say start there, would be my thought.
Thank you. Dr. Karkar, anything to add there on a few high priority strategies that you would recommend HIV programs consider integrating?
Yeah, I think for general primary care setting, you know, at DAP Health, we pretty much do screening. And we have a sexual wellness clinic, which is where a lot of the patients that have, you know, need to screen are screened frequently. In fact, the 20,000 that was screened, they were all not 20,000 patients, but some of them were on PrEP and screened for hepatitis C and so forth. So I think in general, you know, there is provider knowledge deficiency and training. You know, I give a lot of talks to residencies or residents who are in family medicine, who are going to be future primary care providers, because that is where you know, it needs to be grilled. And you know, I am not 100% sure, but we have a methadone clinic, and they are not required to test for hep C. So they don't have the budget to test, and that's that's something we need to address. Why not? We even have collaborated some meetings with the medical directors of methadone clinic to see if we could do not just provide the free testing, but collaborate with them to get those people cured through directly observed treatment. Some of these ideas have been tossed around, but I don't know if they will ever find a plan and come to fruition. That's what I have to say.
Thank you. Thank you. Brian, how about you? Any kind of recommended high priority strategies that HIV programs consider integrating?
Yeah, I mean, I'm fortunate at APLA Health in our 4 clinics that we have experienced HIV doctors who have integrated Hep C care. And in LA County, there's quite a few FQHCs like us that have done that as well. JWCH, Altamed, St. John's, many others. But I think a primary focus needs to be on the HRSA-funded sort of second round and third round FQHCs who have EHE grants to provide HIV prevention care and to get them to integrate bundled testing into that HIV prevention care. And so I've been involved in some capacity building with these FQHCs, and a lot of them are just starting to staff and create protocols to provide testing and PEP and PrEP, and it would be easy to help them get their protocols to also incorporate bundled testing with Hep C and to know what referrals they have, because we have a lot of FQHCs like APLA Health, like JWCH, like the other ones I mentioned, where they can refer. So in any geographic area, the service provider area in LA County, there's a FQHC that they could refer to for if somebody tests positive for Hep C.
Thank you. Lena, I'm wondering if you have anything to add from the pharmacy perspective around, potential strategies that folks can consider integrating into their HIV programs to address viral hepatitis.
Sure, definitely. So I actually am the primary pharmacist that runs the hepatitis C clinic along with Dr. Karkar at Desert Oasis. And we've been doing a lot of, at least in our medical group, we've been doing a lot of outreach to the primary care providers, other specialists that patients see to kind of educate on the highlighting on how much patients can really benefit from the testing. So that we can increase our numbers for testing, and then we can therefore increase our numbers to link it to care. And so that all those referrals from our specific medical group, at least the people that we serve in our valley, can come to our hepatitis C clinic right away, get that treatment started for everything. So for us, it's kind of educating the primary care physicians and others that might not be that comfortable with prescribing these types of specialty medications. So that's kind of what I have to say about at least how our group is working so far.
Wonderful, thank you. So another question that we commonly got was about outreach strategies, particularly, recommended outreach strategies to reach people who inject drugs and to link them to hepatitis prevention and treatment. And so maybe this time starting with you, Dr. Karkar, can you share any, specific recommended outreach strategies that you all have, successfully used to reach this population?
Yes. So if you remember my slide that had novel collaboration or novel strategies, one of those was the residency programs had a backpack day. They would go in a van to outreach in places along, the places where drug addiction and homelessness and places that they would provide primary care testing as well, HIV, Hep C testing, and then arrange for link to care for those that test positive. But it is very challenging. The other option was street medicine. It's called street medicine. Actually, the program at both hospitals had that. Everything kind of came to a halt during COVID because in infectious disease, we had other suddenly priorities that sort of divided our attention. And I'm not sure if they are back again, but I suspect they are. But we lost ground. The other thing that was, we have collaborated with methadone clinics and other clinics that do rehabilitation for drug addiction to promote testing. Trying to think. So there are ideas that need backing from the standpoint of financial, economic process, and some of it is really the main barrier to why we cannot do everything that we think of. But
yeah, thank you for that. And I appreciate, I know you highlighted also in your presentation some of the challenges with, redirecting efforts during COVID-19 and now, figuring out your process moving forward, which I know in previous sessions, many of our panelists and attendees have kind of spoken to those struggles as well. Lena, do you have anything to add to Dr. Karkar's comments?
Yes, definitely. We actually have quite a few patients that we see who are in between homes or don't have an address or a cell phone even that we can really reach them at. So one resource that we really like to utilize is social services or some type of a case manager that we can get involved with the patient's care. Usually we can get either the primary physician or if they see a specialist, somebody to kind of get on board with coordinating that. And we sort of try to go through all of the steps with the testing and the treatment and the lab monitoring through them. They also help with transportation services. Sometimes we can get grants approved for those people too through social services case management. So it's a very interdisciplinary approach that we use with all hands on deck. So
thank you. Brian, any recommended outreach strategies that you'd like to offer?
Well, I mentioned in my overview of the work of the Hep C task force over the last 20 years, we about 15 years ago started the outreach model of the Hep C retreats. So it would usually require probably 5 of us from the task force with a clinician to do outreach at various drug treatment facilities, hospitals, clinics that served post-incarcerated population, anywhere where people were at risk or where they were providing testing. It might have people newly diagnosed for Hep C, where we could help with linkage, where we would provide basically education. We've done about 40 of these in the last 20 years. And so that's our outreach education model. And, it's sort of done efficiently in about 4 hours where the clinician speaks, we provide lunch, they have a support group, we talk about advocacy, and self-care for people there, and then just answer their questions around where they can get treatment or where they can get tested. And so just the ABCs of viral hepatitis, and that's been a successful model for us. Obviously, I have to raise funding every year for us to do that.
Thanks, Brian. And Rachel, anything you want to add about recommended outreach strategies?
I think really just going where the people already are is the main thing. I just posted a link in the chat. We funded 5 projects across the state from 2016 to 2018 to really identify these lessons learned and best practices. And we published an evaluation report. It's long, but please don't be daunted. It's basically like 20 pages of the main findings and then like a profile for each of the sites, including sites in Los Angeles, San Diego, San Francisco, Butte County, and the Central Coast. So I would just encourage people to check it out because there's a lot of really good nuggets in there about how to do the work.
Wonderful. And I can go ahead and share that resources with participants after the session as well. So thanks for sharing that. All right, so we just have a few minutes left, but another common question that we got was, how can people best be supported through hepatitis treatment? So how can we as service providers really support people through that journey of treatment? And Brian, maybe starting with you for this question, any recommendations when it comes to supporting folks on treatment?
Well, as we've heard, treatment is much easier today than it used to be. So, 8 to 12 weeks is not a very long time to kind of provide that supporting guidance. Whereas before, as Rachel and Dr. Krakar mentioned, the treatments had a lot of side effects, and they had like 40 and 50% efficacy. And so very, very frustrating. That's where there was a lot of need for care and support. I think any patient navigator, any case manager, any outreach person on the clinical staff can provide that. There are minimal side effects to the Hep C treatments, and it's just making sure that people are being adherent and supporting them in that, and giving them congratulations when they complete the treatment, or get to a sustained virological response in the first 4 weeks. I know that Dr. Tony Martinez in Buffalo, he has his great clinic model where every time somebody completes successfully their Hep C treatment, they ring a bell, they have balloons, they make it festive and supportive for that person. Those are the kind of things that incentives that we can provide to help people with treatment. But fortunately, it's much easier.
Thank you. Thank you so much. And I love that, the celebratory ideas you shared there. Rachel, any comments from you about just ways to support folks through hepatitis treatment?
Yeah, I really agree with Brian. It's not about the meds. It's all about the logistics, like appointment reminders, transportation, incentives. Like, if people have an appointment, can you give them a gift card, or even, like you said, like something else celebratory, like a positive reinforcement. It's not like the side effects are not the problem. If you look at the data on Hep C treatment, like the sickest people got treated first, which made sense. The people who were ready to go and were like waiting for these new meds got treated first. And now who we have left to treat are the people who, they're not the hardest to reach. they're the people who we, as a system, we fail the most, if that makes sense. They're there, we just have to bring our services to them. And so it's really helping people overcome logistical barriers. A lot of it is, you know, people might get arrested and go to jail, or maybe they go to the hospital, or maybe they, you know, they have a crisis of some kind. And so it's just providing that consistency and support for people. And again, we talk about this in the evaluation report, but that for some people, if they fall out of treatment, if you're consistent, you have a syringe exchanges in the same place at the same time for 3 years, maybe they disappear for 6 months and then they come back, and then you can re-engage in care. So yeah, those are just some thoughts.
Thank you. Dr. Kirkar and Lena, if you want to take us out on this question, can you share any kind of perspectives clinically about ways to best support treatment of hepatitis?
I'll just say that, what we have been doing is promoting every patient, one patient at a time. At least what I've been doing is I engage them at their first visit. Whenever they are sitting in front of me, I tell them, you're considered cured, because the hardest part was getting to me. And number two, I advocate for them while they're going through the treatment, because I see them about 2 times minimum. And at that time, one of the things to say to them was, you need to go to your circle of friends, your circle of family members, your community, the people you hang out with, and tell them how you are being treated. And what is going to happen is that they need to know their hepatitis C status, that there is free testing available, that they should advocate their uncles, aunts, mother, father, no matter what, have they been tested, and that they would be able to get treated and cured. The other thing is we don't turn away anyone. Every patient that lands in our clinic, even if they fall through the cracks, they have heard this one 40-minute rant that I educate them, because I feel like that's my only chance to reach maybe 5 other people that they can advocate. They have advocated to their circle of people to get tested and get linked to care. The other part about treating one patient at a time, I think, is extremely important, because if you put the thought in them, even if they get lost, they find you back. So I have found that happening quite frequently in the population that I am trying to reach. And it's still a process that even if it's short, like it was 1 year or whatever, 52 weeks of Pegasus and ribavirin, and then we went through all that, and only 35 to 45% have been cured. The risk of reinfection is what I stress the most at the time that they are going through their cure treatment, is how you're going to protect yourself from getting it again, and providing them to understand what their risk factor was, because that's how they're going to be able to protect. If they were a drug user, they needed to know that the least they can do is that if they ever use drugs, not to share needles, not to share equipment, not to share anything. If they're gay men, counseling them about that risk, even if they are on PrEP, is extremely important, because we do see reinfection in gay men with Hep C. And HIV Hep C, of course, we are screening them more frequently, even during the time that they have been cured. So these are some of the things that are so critical. And even though I believe that every primary care doctor can treat Hep C, I think that every clinician that is planning to treat Hep C should have some sort of a background extra knowledge. It doesn't need an infectious disease specialist or a gastroenterologist or a specialty clinic. But if all these elements are understood, every clinician, every provider can rapidly treat Hep C. I think this is the easiest part where we are right now, is to treat Hep C. The part that's the hardest is finding the people that have it, the asymptomatic ones, to get to them before it's time, that it's too late. Because I do see a lot of patients with liver cancer at the time of diagnosis and at time of referral. And dilemmas of those sort are extremely important to spread the information about getting tested. There's nothing more important than the part before they come, because the part that is the easiest is the treatment.
Thank you. Well, thank you all so much. I know unfortunately we're out of time for today, but I really want to again thank our wonderful panelists for sharing your amazing work and your fantastic insights with all of us today, and also all of our attendees on the line for your great engagement in the discussion and your questions. Also, my colleague Enrique Sanchez for your very helpful technical support on the line with us. And as usual, please do look out for a follow-up email from me with relevant information from the session, the slides and recording, and a link to the evaluation form. And thank you all again. Have a wonderful afternoon. Bye, everyone.
Thank
Thank
you.
Thank you.